sign, and this is a multi-level ACDF with expandable cages for fixed kyphotic spondylotic myeloradiculopathy, obviating a posterior reconstruction, presented by Dr. Poelstra.
Good afternoon, everybody. I want to thank NASS for the ability to present this. I acknowledge my co-authors and have a slide with their disclosures. The clinical problem I want to address with you guys is the multi-level ACDFs, whether you have to go to the posterior column or not. As you guys know, if we review multi-level ACDFs and their problems, multi-level cases that do not get reconstructed with normal sagittal valves have an increased likelihood of having adjacent segment disease. You guys know the fusion rates of 3 or 4 level cases go down to 80 or sometimes 60% in some of the cases, depending on implants being utilized and technique utilized. The subsiding rates are an issue, and when you start to subside and the patient's neck goes forward, the potential for additional pseudarthrosis is there, of course. And then the posterior reconstructions, like we talked about, sometimes after 3 or 4 level ACDFs, are somewhat burdensome. We know that people have more infections from that, comorbidities with those cases. They hurt. If you pick up the phone yourself as a surgeon and not covered by residents and fellows, you know this is not an appealing thing to do in a private practice setting. So we like anterior surgery. We think that jacking up, though, however, something with just a brick might not be the ideal thing. So what we're going to talk about is the ability to get restoration accomplished on the anterior with an expandable device. So an expandable cervical device, although this is not, of course, like a commercial, there's only one company that has it currently available, and it's called the HiJAK from Atlas Spine. I was privy to the first 25 cases, and this is a very nifty device that allows you 20 degrees adjustable lordosis that's very easy to dial in. It has anterior and posterior expansion. It actually helps for more of an indirect decompression, so it doesn't squeeze the foramen. That's not the fulcrum. The fulcrum is posterior to the spinal column. There's multiple footprints. There's treated end plates. Actually, there's quite a nice opening, as you can see, for bone graft, and post-filling after expansion allows for expansion of the graft through that opening, and eventually, for me at least, an idea that I could potentially still have a fusion there. So if we look at my first 25 cases, again, this is short follow-up and a small number of patients, 13 males, 12 females. 50% of these cases were patients that were in my practice. I did 65 levels with these 25 patients. Some of these patients were hybrid cases, which we'll discuss. There were 12 patients in the 1 to 2 level and 13 patients in the 3 and 4 level, sort of more complex cases where you potentially would go to the posterior column. Their age is sort of the Medicare population, as you can imagine. Standard comorbidities, these are all comers, and diabetics and smokers were in there. I tried not to change the world and let people decide they have to stop smoking. We don't exclude them if they have nicotine levels that are still there. The mean time since surgery was 7.5 months follow-up at this point, and I did 7 of these 25 cases as sort of hybrid cases, where sometimes I did not feel the need to put an expandable cage, and I placed a standard titanium cage, as you can see as the top there as an example. So if we look at the initial lordotic reconstruction with this, I was very pleased with this. The ability to expand the levels up to almost 9 degrees per level is very consistent and much of greater significance than I was able to do with a static cage. 0 to 8 week average loss, but we only saw potentially some reduction in that lordotic angle was less than 0.6 degrees per level. There was minimal subsidence despite the correction angle, so despite pushing against these end plates, subsidence was low. Fusion status so far in the first 3 months with flexion extension fuse was 25 to 28 meshes levels fused, and more follow-up is coming. Clinically excellent improvement throughout, and 0 revisions in 25 patients. From the first 350 implants, the company told me there were no revisions whatsoever. And I'll give you a classic example. We all see this right in the private practice deal. 74-year-old smoker, myelopathic, clonus, Hoffman's, neck pain, some injections in the past, but suffering really for small of a decade, unable to look straight ahead. And in this case, people would argue I do a multi-level anterior and then potentially go posterior. So in this case, for the reconstruction, I did a 3 to 7 ACDF. After implantation of the cage, which already caused some lordotic correction, an additional 7 degrees was achieved per level, and an average posterior decompression of indeed 1.25 millimeters, again, showing that you don't squeeze the foramen, but you actually lift up the back of the vertebral body ever so slightly. And this is a standard result here with excellent neurologic recovery, post-standing radiographs. After 3 months, you can see a 60 degrees kyphosis turning into 20 degrees lordosis, partly because, of course, positioning, but also I think the implants per level increase single lordosis definitely helped. 40-degree correction is pretty much standard in this patient population that I have here. So I think if you look at the problem, turn it into a solution, looking back at the sagittal balance that we talked about, I think there's a possibility to dial it up, and especially with the cages giving you up to 20 degrees of correction per level is helpful. The fact that none of it infuses is partly due to the fact that people still lean forward, right? So if we recreate a well-balanced spine, the load is evenly distributed, and there's a higher chance of patients fusing. The subsidence rates here that we've seen are less, I think, than what I would have anticipated with an expandable implant, because you are less aggressive hammering that implant in there. You dial it up after you place the implant without any serration on the bony end plate, and less this bony resection, I think, helps with that. And I think the anterior ability to do this gives us correction and stability from the front in select cases, and I think there is truly a possibility for expandable interbody cervical technology. I think everybody agrees that this is a bad idea, and that's something that slowly jacks it up into much more reliable and safer for our patient population. Thank you so much.